Hello, I'm Dr. Walaldin. Welcome to the MRCP Part 2 High Yield Revision Series. Let's get started.
Hello and welcome to Dr. Walaldin Revision Series. In this session, we're going to walk through one of the most important clinical syndromes you will encounter in acute medicine, acute heart failure. This is a comprehensive guide to recognizing, diagnosing, and managing AHF in adult patients. It is in every sense an urgent topic. Let's start with the definition. Heart failure is a clinical syndrome, not a single disease, but a collection of symptoms and signs caused by an abnormality of cardiac structure or function. Now, what makes it acute? Acute heart failure refers to the rapid onset or sudden worsening of those symptoms and signs. This demands urgent medical evaluation and treatment. There is no room for delay here. This overview covers adult patients only. Pediatric and pregnant populations are not included. And here is our first key point. And please do take note of this. Acute heart failure is not a diagnosis in itself. It is a clinical syndrome. Your job is to identify the underlying cause. That is essential. So, what should make you suspect acute heart failure in your patient? There are 4 cardinal presentations to recognize. First, breathlessness. This can be acute onset, orthopnea, meaning breathlessness when lying flat, or paroxysmal nocturnal dyspnea, where patients wake gasping from sleep. Second, ankle swelling, bilateral pitting edema that reduces with elevation, a classic sign. Third, reduced exercise tolerance. These patients fatigue earlier with physical activity. Something that was easy before is now a struggle. And fourth, fatigue and tiredness, with increased recovery time after any exertion. Now, if any of these features are present, your next step is critical. You must immediately assess for life-threatening causes. These include acute coronary syndrome, hypertensive emergency, cardiac arrhythmias, and mechanical causes. On the right side, pulmonary embolism, severe infection or sepsis, cardiac tamponade. These are the conditions that will kill your patient if missed. Assess for them urgently. This brings us to a slide that could save a life in your ward tonight. When to escalate. When to call for cardiology or critical care. Request urgent specialist support if any of the following are present. Respiratory distress or failure, a respiratory rate above 25 per minute or SpO2 below 90%. Reduced consciousness, confusion, drowsiness, unresponsiveness. Heart rate extremes below 40 or above 130 beats per minute. Low systolic blood pressure below 90 millimeters of mercury. Persistent hypotension. Signs of hypoperfusion, cold extremities, oliguria, narrow pulse pressure, hemodynamic instability, deteriorating perfusion and organ function, acute heart failure due to ACS requires immediate specialist input, and persistent life-threatening arrhythmias. These patients require treatment in a cardiac care or high dependency unit. Escalate early. Now let's move to investigations, and the rule here is simple. Always order these in all suspected cases of acute heart failure. First, a 12-lead ECG. Record it and interpret it continuously. Use it to rule out ACS, arrhythmias, and previous myocardial infarction. Important note, a wide QRS or bundle branch block indicates a worse prognosis. Second, chest X-ray. Look for pulmonary congestion, pleural effusion, interstitial or alveolar fluid, and cardiomegaly. But here is a critical caveat. LV dysfunction can exist without cardiomegaly on the chest X-ray. Do not be falsely reassured. Third, natriuretic peptides, specifically NT-proBNP or BNP. These differentiate cardiac from non-cardiac causes of breathlessness. Normal levels make AHF unlikely. Elevated levels suggest AHF, though they can be raised by other conditions too. Fourth, standard blood tests. Troponin, elevated levels indicated poorer prognosis, full blood count for anemia and iron status, electrolytes and renal function, critical for drug decisions, glucose and HbA1c, liver function tests, and thyroid function tests. And the practical take-on tip? Interpret all results together. No single test confirms acute heart failure in isolation. Let's dig deeper into natriuretic peptides and when to arrange that echo. For NT-proBNP, we use age-adjusted cutoffs. Under 50 years old, above 450 nanograms per liter suggests AHF. Between 50 and 75, above 900. And over 75, the threshold is 1,800 nanograms per liter. A caution worth noting, female sex may modestly elevate NT-proBNP levels, and elevated levels can also occur in ACS, pulmonary embolism, renal impairment, liver disease, and simply with older age. Always, always interpret in clinical context. Now, echocardiography. It is the gold standard for assessing cardiac structure and function, and the timing matters. Box 1. Urgent echo. Immediate bedside echocardiography. For patients who are hemodynamically unstable, in respiratory failure, or showing signs of shock. Requires specialist expertise. Do it at the bedside without delay. Box 2. Stable echo. Within 48 hours. For stable patients, echo will assess LV and RV systolic function, diastolic function, valvular abnormalities, shunts, and critically, the left ventricular ejection fraction, the LVEF, which is key for long-term care decisions. This brings us to an absolutely fundamental concept, classifying heart failure by the LVEF, the left ventricular ejection fraction. There are 3 categories. First, HFrEF, heart failure with reduced ejection fraction, LVEF at or below 40%, the most common type. The left ventricle is structurally weakened. Most evidence-based treatments apply here. There is also an important subgroup, HFIMPEF, where the LVEF improves to above 40% with treatment. Second, HFmrEF, heart failure with mildly reduced ejection fraction, LVEF between 41 and 49%. This is a transitional category, sometimes called the gray zone. The evidence for HFrEF therapies here is less certain, but SGLT2 inhibitors are recommended. Third, HFpEF, heart failure with preserved ejection fraction, LVEF at or above 50%. The LVEF appears normal, yet structural and functional abnormalities are present. This type tends to affect older patients and is often underdiagnosed. SGLT2 inhibitors are recommended here too. Remember, the classification guides long-term pharmacological strategy. Always confirm with echocardiography. Now we get to management, and we begin with goals. 6 of them. 1. Treat the cause. Identify and treat whatever is driving this. 2. Relieve symptoms. Alleviate breathlessness and discomfort. 3. Reduce congestion. Improve organ perfusion. 4. Restore oxygenation. 5. Protect organs. Limit cardiac, renal, and hepatic damage. 6. Improve long-term outcomes, quality of life, and survival. On the right, we have initial supportive care and 3 important interventions. Oxygen therapy, give oxygen only if SpO2 is below 90% or PaO2 below 8 kilopascals. Critical caution. Excess oxygen, above 96%, is linked to higher mortality. If there is a risk of hypercapnia, target SpO2 between 88 and 92%. Non-invasive ventilation, CPAP or BiPAP, consider if respiratory rate is above 25 or SpO2 below 90% with respiratory distress. Invasive ventilation, reserved for severe respiratory failure with hypoxemia, hypercapnia, or acidosis. And the underlying principle, careful monitoring. Every parameter matters. Now, 2 critical hemodynamic scenarios. Scenario 1, cardiogenic shock, systolic BP below 90 millimeters of mercury. This requires urgent cardiology and critical care support, a specialist environment. Vasoactive drugs, inotropes and vasopressors, short-term IV agents to raise cardiac output, blood pressure, and organ perfusion. Use only in cardiac care or a high-dependency unit. Consider only for reversible shock or in transplant candidates. Mechanical circulatory support, IABP, Impella, specialist decision only, bridge to recovery or transplantation. Scenario 2, hypertensive crisis, acute pressure overload. Here, intravenous vasodilators are first line alongside usual care. The priority goal is relief of dyspnea. Keep systolic BP above 90. Drug options include glyceryl trinitrate, isosorbide dinitrate, and sodium nitroprusside, though that last one is debated with differences between NICE and ESC guidance. Evidence note. No strong survival benefit has been proven with vasodilators. They are used for symptom relief and BP control. Both states require continuous monitoring. Heart rate, BP, SpO2, urine output, and renal function. Refer to specialist early. For patients with normal blood pressure who are not in shock, the core treatment is congestion management. The cornerstone drug, IV loop diuretics. Give if signs or symptoms of congestion are present. Starting dose should be at least equal to or twice the patient's pre-existing oral dose. Administer as intermittent boluses or a continuous infusion. Adjust based on symptoms and clinical response. Target weight loss, 0.75 to 1 kilogram per day. Monitor renal function, electrolytes, and urine output carefully. And here is a warning worth emphasizing. Avoid excessive diuresis. It is more dangerous than the edema itself. For resistant edema, consider adding a thiazide-type diuretic or an aldosterone antagonist. Monitor closely for electrolyte imbalance, renal impairment, and hypovolemia. What about beta blockers? If the patient is already taking them, continue. Do not routinely stop. Only stop if heart rate falls below 50, second or third degree AV block is present, or the patient is in cardiogenic shock. Final caution. IV vasodilators should not be given routinely in stable patients. Consider only for myocardial ischemia, aortic, or mitral regurgitation. Now we turn to long-term management, specifically for patients with HFrEF. LVEF at or below 40%. The principle: start low, titrate to the maximum tolerated dose. The 4 pillars of HFrEF therapy. Pillar 1, ACE inhibitor, or ARB if intolerant. First-line cornerstone therapy. Reduces afterload and neurohormonal activation. Start low, titrate slowly upward. If the patient remains symptomatic on optimal ACE dose, switch to sacubitril valsartan. Pillar 2, beta blocker. Reduces heart rate and myocardial oxygen demand. Use a heart failure licensed beta blocker. Ensure stability for at least 48 hours before discharge after starting or restarting. Pillar 3. Aldosterone antagonist. Add to ACE and beta blocker therapy. Reduces fluid retention and fibrosis. Monitor potassium and renal function closely. Pillar 4. SGLT2 inhibitor, dapagliflozin or empagliflozin. Add regardless of diabetes status. Reduces heart failure hospitalization and cardiovascular death. Avoid in type 1 diabetes due to DKA risk. Sacubitril valsartan replaces ACI or ARB when still symptomatic on optimal therapy. May be considered first-line by a heart failure specialist. Intravenous iron for symptomatic iron-deficient patients. Alleviates fatigue and breathlessness, improves quality of life, and reduces future hospitalizations. And finally, refer early to the specialist team for consideration of ivermectin, CRT, ICD, digoxin, transplantation, and mechanical circulatory support. For our patients with mid-range and preserved ejection fraction, the approach is different, but SGLT2 inhibitors remain central to both. For HFmrEF, LVEF 41 to 49%, an individualized care plan based on clinical profile and comorbidities. Consider the full HFrEF therapy toolkit: ACE inhibitor, beta blocker, aldosterone antagonist, and sacubitril valsartan, SGLT2 inhibitor regardless of diabetes, and diuretics for congestion relief. For HFpEF, LVEF at or above 50%, treat the underlying risk factors in etiology. Screen and manage comorbidities, especially in older patients with multiple conditions. SGLT2 inhibitor, again, regardless of diabetes, and diuretics for congestion. Shared recommendations for both. Specialist referral, ensure heart failure specialist team input, and cardiac rehabilitation, offered before discharge, personalized, exercise-based, addressing physical, psychological, and educational needs. Discharge is not just about the patient feeling better. There are specific criteria that must be met. Before discharge, confirm all of the following: an up-to-date echocardiogram within the past year or completed during this admission, reviewed by the heart failure specialist team, patient is stable and euvolemic. Persistent congestion at discharge is associated with higher readmission rates and increased mortality. Established on recommended oral medications, and hemodynamically stable for at least 48 hours, especially after starting or restarting beta blockers. After discharge, next steps. Follow-up appointment with a multidisciplinary heart failure team within 2 weeks of discharge, cardiac rehabilitation referral offered before discharge, and a self-management plan. The patient must know when and how to seek urgent medical attention. This is an exciting space. Novel pharmacological agents under investigation. Promising, but with evolving evidence. Acetazolamide, a carbonic anhydrase inhibitor, enhances decongestion when added to loop diuretics in volume overload. Further outcome data still needed. Sotagliflozin, a dual SGLT1 and SGLT2 inhibitor, FDA approved, reduces cardiovascular death, heart failure hospitalization, and urgent heart failure visits. Not yet approved in Europe or the UK. Tolvaptan, a vasopressin antagonist, promotes aquaresis, water excretion, may treat volume overload and resistant hyponatremia. Cinepezide, a vasodilator, improved symptoms and fewer adverse effects versus dobutamine in decompensated heart failure. Vericiguat, a soluble guanylate cyclase stimulator, oral agent, EMA and FDA approved, reduces cardiovascular death or heart failure hospitalization in chronic HF patients. And a number of agents remain under investigation, some promising, like ularitide, istaroxime, relaxin, and cardiac myosin activators, Others have failed to show benefit, including ralophylline and tonopafilline. The bottom line, evidence continues to evolve. Always refer to current guidelines before clinical application. Now, the bigger picture: prevention, monitoring, and what happens in the long run. Primary prevention: control coronary artery disease risk, aspirin, beta blockers, statins, ACE inhibitors, optimize hypertension, smoking cessation, and lipid management. Aggressive diabetes control: SGLT2 inhibitors reduce heart failure hospitalization in type 2 diabetes with cardiovascular risk. Avoid excess alcohol, salt, and fluid in known LV dysfunction, and avoid drugs that cause or worsen heart failure. Secondary prevention: vaccinations for all heart failure patients, pneumococcal, COVID-19, annual influenza. Patient education and self-management: restrict fluid and salt intake daily, limit alcohol, strict medication adherence, daily weight checks. Sudden weight gain equals fluid retention. Know when to activate the self-management action plan. Monitoring: acute phase, continuous cardiac monitoring, renal function and electrolytes, heart rate and blood pressure, and close clinical observation, especially with beta blockers, ACI, diuretics, and aldosterone antagonists. Post-discharge: specialist HF team follow-up within 2 weeks. Regular aerobic exercise for stable patients, and enroll in multidisciplinary care management. Prognosis: and we must be honest here, in-hospital mortality is approximately 11%, with a range of 6 to 26%, and 5-year survival remains poor across all LVEF types. Adverse outcome predictors include hypotension, renal dysfunction, older age, male sex, ischemic etiology, elevated troponin and BNP, anemia, hyponatremia, high respiratory rate, and multiple comorbidities. One positive note: specialist cardiology ward care is associated with reduced mortality. This matters. Get your patients the right care. AHF treatment carries inherent risks. Vigilance and proactive management are essential. Arrhythmias: high likelihood, frequently precipitated by AHF, especially atrial fibrillation. AHF itself can also trigger arrhythmias, creating a dangerous cycle. Management: identify and treat the underlying cause urgently. Continuous cardiac monitoring is essential. Glyceryl trinitrate side effects: high likelihood. Commonly causes headache and hypotension. Headache is usually mild to moderate and self-resolving. For hypotension, reduce the infusion rate first. If persistent, discontinue and restart once stable. Diuretics: medium likelihood. Overdiuresis leads to worsening renal function, hypotension, hypokalemia, and neurohormonal activation. Can also potentiate digoxin toxicity via hypokalemia or reduced GFR. For worsening renal impairment, reduce the dose. Severe cases, withhold and reintroduce at a lower dose. Inotropes: medium likelihood. Dobutamine and milrinone can cause arrhythmias and worsening coronary ischemia. For sustained arrhythmia, discontinue the inotrope. For ischemia, discontinue immediately. Consider amiodarone if the inotrope is essential. Remember, all complications require close monitoring of renal function, electrolytes, heart rate, and blood pressure throughout treatment. Monitor closely. Finally, a note on where our evidence comes from. These guidelines inform everything we have discussed today, and knowing your local references matters. In the United Kingdom, NICE 2021, Acute Heart Failure, Diagnosis and Management, NICE 2014, ICD and CRT for arrhythmias and heart failure. In Europe, ESC 2021 Guidelines for Acute and Chronic HF, ESC 2023 Focused Update, Diagnosis and Treatment, and the CCS-CHFF 2021 HFrEF pharmacologic standard of care. In North America, AHA, ACC, and HFSA 2022, Management of Heart Failure, Canadian Cardiovascular Society 2017, Academy of Nutrition and Dietetics 2018, and MCS Device Strategies and Patient Selection. In Oceania, National Heart Foundation Australia and CSANZ 2018, Prevention, Detection, and Management of Heart Failure in Australia. The message is clear. Always refer to the most current version of your local and international guidelines for clinical decision-making. And that brings us to the end of this overview on acute heart failure. We have covered the definition, recognition, investigation, classification, management, discharge, complications, and the evolving landscape of new therapies. Remember the essential message. AHF is a clinical syndrome, not a diagnosis. Find the cause, act urgently, monitor closely, and always think long-term. Thank you.
If you found this video helpful, I'd really appreciate it if you subscribe to the channel for more high-yield MRCP Part 2 revision content.